In terms of the outcome and what preceded the outcome, really probably the most remarkable event that I've managed in that time.
And what makes it stand out?
First of all, it occurred in a rural area in Minnesota, out of our urban fast response police system. It occurred in a relatively young man who underwent remarkably prolonged resuscitation with relentless recurrence of a potentially fatal rhythm, from which eventually we were able to retrieve him. And then he underwent interventions here at St. Mary's that ultimately led to a virtually complete recovery. And it was a sequence and a scenario that would be hard to duplicate.
Wow. So walk me through a little bit about, first of all, what set it up to be the remarkable recovery it is now, or has been, to the kind of the stage of events that took place?
Well, first of all, the arrest was witnessed in that rural area, and first responders were able to get to the patient quickly, I think somewhere in the range of 3 to 4 minutes maximum. And they intervened then for a series of 6 defibrillation shocks for recurrence of the rhythm that ultimately would have been fatal had we not been able to remove it. And then we arrived, and we had a whole group of people who participated in the ongoing resuscitation, which seemed like it would never end. But everybody worked together in what had to have been a remarkably harmonious manner to achieve what we saw in retrospect in terms of what was happening during the arrest and resuscitation, and of course then what ultimately happened when he recovered completely. So it was from the moment it happened, when first responder people in a rural community were able to intervene quickly with a device from which we were able to capture all of their data, and then our arrival, and we captured additional information that confirmed that what we were doing was potentially salvageable, and that if we kept doing it, there was a good chance that we could get him back and get a recovery from it. It was the duration that made it so difficult and made it seem at times like this isn't going to work.
And what do you think kept these people motivated to keep going?
Well, I think there were a couple things. First of all, it was witnessed. That's always a good sign for us to start with. Secondly, he was intervened by the first responders with a good response. And thirdly, during the resuscitation, he was showing visible signs of life by movement of his upper extremities. And secondly, we had the advantage of monitoring a measurement of the adequacy of blood flow through the lungs and therefore to the brain throughout the resuscitation. And that measurement, which a lot of people just don't use, told us that blood flow was adequate, and that if we could possibly reverse the rhythm that kept recurring and that would lead to death if we couldn't reverse it, we'd have a chance of recovery. So the aim was to take advantage of what appeared to be an ongoing successful resuscitation in terms of CPR, but can we get rid of the rhythm that keeps recurring and putting him right back into cardiac arrest? And so we had a primary aim was to get rid of that rhythm. And if we could not get rid of that, no matter how good the CPR was, he would not have recovered.
And what were the steps to get rid of that lethal rhythm?
Well, it was a combination of 3 things: the ongoing CPR, the administration of drugs that hopefully would reverse the irritability in the heart that was causing this to happen, and thirdly, the repeated shocks that were given to stop the VF, ventricular fibrillation, in its tracks, and hopefully one of the shocks would permit a stable circulation return. Well, it took 12 of those shocks to get him there, and it took a whole lot of drugs to get him there. But that combination with ongoing good CPR enabled us to get a good outcome.
And now you were in contact with one of our crew members, our flight paramedic, Mayo 1 flight paramedic, by phone, and describe to me, if you would, Dr. White, on how, how you could use just by hearing the description and getting that data from that device, on how you were able to consult with the crews on scene.
Yeah, Bruce contacted me into the resuscitation, and he said, "This is what we have, and we're not getting anywhere. We get him out of ventricular fibrillation with a shock, and he goes right back into it. And this is recurring over and over again. And you're going to have to help us with something because he's showing signs of life, and we don't want to quit, but we have to get him out of ventricular fibrillation, and we know we can't keep going like this." So that's when I said, and he kept calling me back and saying, this is what the I kept asking what the carbon dioxide measurement was. And that measurement kept saying, well, this is still something we have to keep pursuing because blood flow is good. So then the end came and I said, Bruce, all we can do is blast him with another big dose of an antiarrhythmic drug. And then wait for a few minutes, circulate it with CPR, and then we're going to try one more shock, which would be number 12. So he got the other dose from the other paramedic ambulance, and we gave it, and we gave the 12th shock, continued CPR for a few minutes, checked the rhythm, and he had an organized rhythm, and then pulses came back. So that was the sequence that said, yeah, we're right against the wall here. What is left that we can do to stop this recurrent ventricular fibrillation and get a stable circulation back? And we just happened to get the right combination at the end that made it happen.
What were your thoughts initially when you saw the it was encouraging when you saw the data from this device to measure his CO2.
Yes.
But what were your thoughts when they've gone through this series of interventions and still has that lethal rhythm? Did it seem like there was much hope?
I was, by the third or fourth call, I was pretty discouraged that we did not have much left in our pockets to stop this fatal rhythm. Even though I knew that we were making good efforts with the CPR, that alone was not going to do it, because if we could not stop ventricular fibrillation, we had nowhere else to go. So it was a difficult time for all of us, including me, deciding what do we do next? How long do we keep doing this? What's left to do? And what was left to do was what we did. And that was what turned him around. It stopped the recurrence of ventricular fibrillation. It never recurred again. And he was able to sustain his pulses throughout the transport right up to the cath lab. So in a way, it was a fortuitous combination of events that led to a good outcome. And yet it was a thoughtful one. I mean, I was thinking, and Bruce was too, what is left to do here? Do we abandon this effort and this man, or can we try something else? And that's when Bruce called me the third or fourth time, I said, we're going to really go after this with a big dose of this certain drug, which was really not ordinarily ever done. But I felt that it was worth a try. And Bruce and Mary administered it. We gave him that 12th shock, and it worked.
How would you today what you've seen with this particular case?
Well, I think all of us who work with cardiac arrest on a regular basis know that CPR works. I mean, you don't have to do a randomized controlled trial to see that cardiopulmonary resuscitation saves lives. But to see it go on like this, for this duration, and to measure its efficacy with an objective indicator of blood flow being generated by chest compressions is unequivocal evidence that CPR is effective in sustaining life. You know, if we hadn't had the CO2 measurement, people might, say, well, what evidence did you have that it was really working, even though you had an ultimately good outcome? But all along the way, we had this measurement that said, yes, blood flow to the brain via the lungs is good. It's near normal. And the only way that could happen is with CPR. There's no other way you can do that. So that, over this long course of resuscitation, confirmed that CPR worked.
Cool.
Yeah.
Can we maybe take a look now and you trace me through the advanced, at least as we have
Yeah,
it?
yeah.
On,
Okay. Can we sit now?
Yep,
Or should
yeah,
we?
go
Okay.
ahead.
All right.
And then we're, Andy, would you want me on this side over here, or?
Yeah, that'll work.
Okay.
Yeah, sure.
So we'll start here with the record that I obtained from the first responder defibrillator. The next morning, Bruce brought the defibrillator from the first responder group to my office. And I downloaded it by infrared analysis into a laptop and then procured everything that you see here. Okay? So this was when the first responders hooked up their device, and that's the time, 17:01. The rhythm you see here is ventricular fibrillation. That's the rhythm with which he started out, which, if it cannot be stopped, is going to be fatal. So here is the first shock they delivered, and the rhythm, as you see, continued. So that shock was ineffective. They continued CPR for another 2 minutes, because that's how the device is programmed. And then it analyzed the rhythm again and said a shock is advised. So shock number 2 was delivered. And for just a few seconds, it looked like it would stop, but then it quickly resumed. So we're still in the same fix. So CPR is continued, and now the analysis says, give another shock. It's delivered here, that's their number 3. And for a few seconds, several seconds, it looked like something was going to happen encouragingly. Reversal of the ventricular fibrillation, you see it here, but then it quickly resumed. So CPR is continued, another shock is advised, another shock is given, and here you see the shock does not terminate the ventricular fibrillation. So we're now into almost 7 minutes. We're still in ventricular fibrillation. This continues. They give a 5th shock for this persistent VF, and this is what happens. A couple of normal complexes, and then CPR is resumed, and VF has recurred. A 5th shock is now delivered for this recurrent VF, and there is a momentary conversion once again. We'll watch what happens though. Ventricular fibrillation resumes. So now we're going to pick up when our paramedics turn their device on. So as you see, these people they've given actually a total of 6 shocks. We use their defibrillator for several minutes while we make our transition. So we're now at 17:47:54. Remember that we started out at 1700. So they've taken several minutes just to use their device to get theirs set up, and then we go on their device. The first rhythm they saw when they hooked up their device is ventricular fibrillation. They're monitoring the carbon dioxide tension now that I mentioned. And when they reported this as 35, I said that's basically normal. That's like what a normal person would get with normal blood flow. So they start their work. They give the first of their shocks. Ventricular fibrillation is still present, but the CO2 is encouraging. This is all through a period of ongoing chest compressions, resuscitation, but ventricular fibrillation still present. They now give the second of their shocks. Ventricular fibrillation momentarily appears to stop, and then it quickly resumes. You see how the CO2 has changed from 33 to 35 to 10, and that's because they had to stop chest compressions in order to deliver the shock. That's how quickly this measurement determined cessation of blood flow. And when chest compressions were resumed after the shock was delivered, the CO2 came back. So now they're on their 3rd shock, and we're struggling with this same problem of ventricular fibrillation. So now you see the CO2 with CPR is back up into where the 34, 35 range. This is all chest compressions in progress. Underlying the compressions is this persistent ventricular fibrillation. Now the rhythm changes to this, what we would often think of and typically would think of as a terminal rhythm with these terribly wide, what we often call agonal complexes in the heart, like a dying heart. But the CO2, when they're doing CPR, is still encouraging. So we shocked that. Bruce said, "This is what I've got." I said, "Shock it." So Bruce gave a fourth shock at this point, and the amplitude changed, but it's the same rhythm. So we're really struggling now, and we knew it. So this is all CPR. All of this stuff here you see is ongoing CPR. CO2 is still pretty good. Look how far we are now. We're 1822. We started out at 1700. So now we've got this to deal with. And again, I told Bruce, let's go. I know it's not VF now. It's a fatal rhythm, but it is still shockable. Shock it. So there's that shock given right there. CO2, it's okay. And now we are in business. We have an organized rhythm with that last shock, which was shock number 12 in the whole sequence. 6 from the first responders, 6 from us. We have no longer ventricular fibrillation. We have what we call an organized rhythm. The CO2 now is totally compatible with a normal blood flow. Not much different, as you see, than it was during good CPR. At this point, I said, this patient, even though it's hard to feel a pulse, even if you can't, I believe he is moving blood on his own. So this is what I called the endpoint from 1700 to 1836. Now, they could not really feel a pulse here until several minutes later. So it may not have been really good flow, but this measurement said it's pretty good. So that's where I took my 96 minutes from. And this was what we were dealing with. He was in cardiac.
Explain to me what this is.
When he arrived here at St. Mary's, he was in what we call a cardiogenic shock. He was hypotensive, and he had what we call pulmonary edema, which means a lot of fluid is in the lungs. This was all consequential to a prolonged cardiac arrest. The cause of all of this difficulty with recurrent ventricular fibrillation was here. He had a fresh clot or thrombus in a major artery in his heart, the left anterior descending coronary artery, which the clot had to be aspirated or removed. The artery had to be dilated and then a stent placed. In order to help his circulation, we put in an artificial device that helps to support the blood pressure. It's called a balloon pump. And he left the cardiac cath lab and went to the coronary care unit. This was 5 January. And it was a long course to get his cardiogenic shock corrected, to get him out of pulmonary edema. He went into acute renal failure. We had to treat that. But remarkably, on 15 January, 10 days later, he was discharged. So this was quite an event. Nothing quite like I've seen. I've seen a lot of stuff, but this was a big one.
Now, what does he have? Does he have an implanted an IED or?
No, he does not.
Okay.
He has the stented vessel here that was done that night. And he has coronary disease in addition to this. So he most likely will undergo a coronary artery bypass operation in the future. That's the plan. Okay. And that should take care of it. And sometimes we do implant defibrillators in them anyway, even though we know this was the cause and we have corrected it. An implanted defibrillator is just an additional protection should for any reason it recur. I haven't had time to put the angiograms up on there yet, but I do have them. And I can show you what, maybe you can even see from this. This was the left anterior descending artery should be right in here. This is a contrast dye that fills the coronary arteries when they are injected. That was before the treatment. And you can see this vessel now, is the one we're talking about here, has now been reopened and is accepting blood flow. You can't even see it here. So this was the benefit of the immediate reopening of his coronary artery and restoration of blood flow to the area of the heart that was causing this recurrent, intractable, relentless ventricular fibrillation.
Wow. Now you talked about, and you showed, I mean, you could see the rhythm, the heart rhythm based on, or resulting from the deep compressions that were being given. What's the value of folks like that first responder group and perhaps others knowing CPR?
Well, it's very unlikely in a setting like this in a rural area, if in the whole period when these 6 shocks were being delivered by first responders, if they had not been doing CPR between the 6 shocks and doing it well, we would have really been in a bad position to get them back. Their initial good interventions enabled us to get someone with whom we could work and achieve an outcome that was good. Had that first period of, I think some 9 minutes or so, whatever it was, had not been adequately performed, this would have been perhaps a fatal outcome. So they were crucial in their actions in determining what we had when we arrived and could now apply additional interventions.
It sounds like there were like 20 plus crew members involved in this. In a case like this, an elongated, extremely elongated case, was that almost a necessity? I mean, in order to do viable CPR, to have that number of people there?
Yeah, I think because, you know, CPR, chest compressions are very physically demanding. They are exhausting. And in our American Heart Association recommendations, we say you should switch off after every like 5 cycles of compressions, because you're going to get exhausted and you're not going to do it well, no matter how well trained you are. So here we were surrounded, as you say, by this large number of people, most of whom at least were able to do efficient CPR and rotate, so that when exhaustion was starting to insert itself, they could switch rescuers who were fresh and ready to pick it up and keep it going. So what an advantage we had with a crowd of people who were capable of participating in this rescue so efficiently and obviously so effectively.
Wonderful. Last thing I have, and that's that on 3.5+ decades of work in this field, Dr. White, how do you explain something like this if you can, and 2, what does it mean as far as maybe hope for future care of patients like this?
Well, I think as long as a patient is in this rhythm, ventricular fibrillation, as opposed to some of the others that can cause cardiac arrest, you have to take a very aggressive position and approach. And I think that was a lesson. It's not that I didn't carry it into this, or wasn't aware of it, but this reaffirmed in my mind that if you really go at this form of cardiac arrest with this irritability, ventricular fibrillation, if you know exactly how to go at it and you have the background support we had here, I am going to really work these harder than I probably ever have, because I think this is an example of what can happen. But we had all the circumstances here that made it work, that we've talked about. All these rescuers, first responders acting quickly and efficiently. So we had a lot of things going for us, but on the other hand, we had a whole lot of things against us. The duration of this unrelenting, recurrent, fatal rhythm that just seemed to refuse to terminate or to relinquish itself to what we were doing, until we finally reached the point where we came up with something that worked. And it wasn't like what we had been doing wasn't the right thing to do. It was all properly executed in accord with American Heart Association standards, but we reached a point where doing the right things wasn't working, and we had to take another step further, and that's when we went for the big dose of this antiarrhythmic drug that we hoped and crossed our fingers would help us stop the VF, and it did. So we crossed over into an area that was a little bit out of the protocol, but we had no choice.